Alrighty. Well, it looks like most people have joined and there isn't more people trickling in. So we'll get started. We have a pretty busy docket today, and we're very excited to talk about all you ever wanted to know about abdominal wall fellowships. We're very thankful for our corporate alliance sponsors. And today we'll be talking all about ab wall fellowship. The agenda for today will include meeting the panelists, learning about abdominal wall fellowships. There will be a component of real-time chat as well as discussion. And so with no further ado, we may as well get started. I'm Vahag Nikolian. I'm an assistant professor of surgery at OHSU and work in our hernia and abdominal wall center. And I did an abdominal wall fellowship back in 2019, 2020 at Columbia University. And today I'm joined by a really wonderful group of surgeons and friends who have really helped, and most of them don't even need any introduction, but we'll do it anyway. First up is Dr. Jenny Shao. She'll be giving a presentation on why you should consider an abdominal wall fellowship. She's currently an assistant professor of surgery at University of Michigan. And directs their abdominal and hernia program. She did a fellowship at everyone's favorite hernia program, Atrium Health at Carolinas, under the tutelage of Dr. Henneford and others. And so welcome today, Jenny, and thank you for joining us. Next up is going to be Catherine Katie Schlosser. She will be giving a presentation on how to decide on a hernia fellowship program. She's wrapping up she just wrapped up fellowship, and she's about to start her first job out of fellowship as an assistant professor of surgery at Beth Israel Deaconess, and did her fellowship at Prisma Health in Greenville, South Carolina. Thank you very much, Katie, for joining. Abhishek Parmar will be doing a presentation on what fellowships are looking for in applicants. He's an associate professor of surgery at UAB and currently is associate fellowship director for their MIS fellowship, which does a very high volume of abdominal wall surgery, robotics, open, and everything in between. He did his fellowship at Oregon Health and Science University in Portland, Oregon. And then Chait Vadlamudi will be presenting on transitioning from fellowship to practice, tips for success. He's an assistant professor of surgery at MedStar Southern Maryland Hospital and did his fellowship at The Ohio State University. And so with no further ado, I'm going to hand it over to our first presenter, Dr. Jenny Shao.
Thanks, Vahag, for that really kind introduction. I'm just going to go ahead and get my slides pulled up here and get this figured out. I hate that when the Zoom screen pops up. Sometimes it doesn't let me. Oh, there we go. So I'm talking a little bit about why you should consider an abdominal wall fellowship, but I really think it can really jumpstart your academic career. So that's kind of what I'm going to focus on. So hopefully all of you guys that are here today are already considering applying for an abdominal wall fellowship. So hopefully those of you that are on the fence, I can convince you to join us on the dark side, or the light side, I should say. So these are some of my financial disclosures. My personal disclosures, as Vahag mentioned. So I did an MIS fellowship that really focused on abdominal wall reconstruction at Carolinas Medical Center with Drs. Henneford and Augenstein in 2019, 2020. I've been in academic practice now for the last 3 years at Penn and now currently at the University of Michigan. So I'm going to be talking a little bit about abdominal wall reconstruction as a subspecialty, list some of the goals of subspecialty training, discuss a little bit of my personal fellowship experience, which I think Katie will probably expound on a little bit, and then a little bit about the future landscape of specialty training. So I think this has been a question that's been posed a lot recently is, should abdominal wall reconstruction be its own subspecialty? And I think there's a lot of arguments for, I think, why that should be the case. And so, we all know, surgery has changed so much since its conception in the 1800s, right? Like we only had one way to do surgery back in the 1850s, and now all of a sudden we have enhanced OR rooms that integrate AI, integrate robotics, integrate all sorts of technology. And so the ways that you can fix a hernia has evolved in that time period. So from 1990, when we were mostly doing open or laparoscopic surgery, to 2022 or slash 2023, where we're using eMelos, we're using robotics, we're using progressive pneumoperitoneum, we're using Botox, we're doing ETAP, we're doing all sorts of things that we haven't done before. And this is definitely a new pioneer. And it changes the way we think about surgery. And so it's not only the improvement in techniques, but it's also the fact that our patients demand better surgeons. They demand surgeons who specialize in what they're operating in. And when you look at high volume hernia centers, the data shows itself that high volume centers improve outcomes and decreases risk of recurrences. So this is just a small center study looking at hospital volume and outcomes in inguinal hernia repair. And you can tell that based on volume, so increasing volume going this way, that the number of recurrences actually decreases over time. And this is significant. But also, fellowship helps practice. Practice makes perfect, right? So surgeon proficiency increases the more we do cases. And so even looking at experienced laparoscopic surgeons, learning how to do a robotic tap for inguinal hernias, on average, it takes about 43 cases to decrease operative time significantly. And so I think all of these things to put together makes a profound argument for why you should think about pursuing a fellowship, specifically for abdominal wall reconstruction. There's also a lot of evidence to show that high volume hernia surgeons practice differently than general surgeon cohorts. And so this is an AHS study that was done back in 2022, and they found that high volume surgeons are more likely to use techniques such as posterior component separation and potentially even higher rates of synthetic mesh in clean versus contaminated cases. So it highlights that your surgical decision making actually changes depending on the specialty training that you would receive. And so what does a fellowship year look like? So these are, this is actually my case log for my fellowship year. And I think the ones that I've highlighted in the middle really have to do with hernia repair. And I think the biggest takeaway from this is just case volume, case volume, case volume, right? Like you just want to do as many cases as possible. You want to see as many things as possible. You want as much case variety as possible. You probably also want to limit your focus. So I know MIS fellowships can be a little challenging because they can include bariatrics, they can include foregut, they can include a huge variety of cases. But I'd say that, you know, if you really are interested in focusing on abdominal wall, I would choose probably no more than one other thing to focus on. So maybe ab wall and foregut, or ab wall and bariatrics, although I feel like with bariatrics, getting both numbers may be a little bit challenging. But really think about what you want to do in a year, because it's a really short period of time. And so I think overall, what my specialty training provided me during my fellowship was just increased expertise and just the ability to see cases that, you know, I never would have seen otherwise in training. So large loss of domain hernias. So this is actually a lady that we operated on when I was in fellowship. So really doing lots and lots of component separations, doing tons of paniculectomies, doing tons of mesh resections for current hernias, bone anchors, you know, robotic techniques for hernia repair, pre-optimization, mesh selection. And I think ultimately at the end of the day, it's not just the technical aspects, it's also the clinical decision-making for complex patients. And just how do you manage your complications? Because when you do big cases, sometimes you get big complications, and knowing how to handle some of these things is just kind of the start to what fellowship can really provide for you. But I think ultimately fellowship can also improve evidence-based practice and patient outcomes. It gives you the opportunity to take part in multidisciplinary case discussions, submit abstracts for publication, oral presentations, participate in national and international conferences, also networking and information exchange, and learning from others in your specialty. And I think this is going to become the future. So some of you may already be aware, but in Europe, there is now a certification for abdominal wall surgery. And so this is something that you can actually take. a test for and be board certified and is abdominal wall surgery. And I suspect that this is something that's going to be potentially coming here to the United States. Maybe not in the near future, but definitely something that's potentially on the horizon. And so I don't want to take up everyone's time too much. I'm really looking forward to everyone's questions because I think that's what most of the session is going to be about. But I really think that looking at the landscape of where we are in abdominal wall reconstruction, I think very specific training and certification is inevitable. And regionalization of abdominal wall cases, especially for complex cases, is coming down the pipeline very soon, which will help hopefully improve evidence-based practice and improved outcomes. But also at the end of the day, you're just joining this incredible community of surgeons, and we all have fun when we get together. So I'm excited to hear what everyone else has to say and look forward to your questions.
That was wonderful. Thank you so much. I don't want to, I was thinking we would have the discussion at the end of all of the presentations because there will be a lot of overlap and a lot of opportunities to discuss. So why don't we move on to the second presentation? Again, it's going to be Katie Schlosser talking about how to decide on a hernia fellowship program. So Katie, go ahead and take it away.
Okay, are you guys getting my slides or the notepad thing?
We're seeing the notepad thing.
Hold on. I'm gonna try this one different way.
You may want to just go to slideshow and just start from.
Do something slightly different. All right, how's that?
Same.
All right, so I am supposed to tell you guys how to decide on a hernia fellowship program. And obviously this is a very individual decision, but I'm hoping to give you some scaffolding for it as well as some things to think about kind of as you go through the process. Who am I? I'm originally from California. I lived away from that great state for a very long time. I went to the University of Vermont and I fell in love with complex hernia then and then kind of forgot about it. And then I spent my first 2 years of training in Bay State Medical Center in Western Mass. And we had one surgeon who did complex hernia and I thought it was the coolest thing. And so I actually did a couple of years of research. I did clinical research over in Charlotte at HM Health and then switched residencies and finished out with the Ohio State. And it definitely was some of my connections in that hernia world that helped me with that transition. I just finished fellowship at Prisma Health and I'm about to start my first job in October in Plymouth, Massachusetts. So what you should get from this presentation. You will get a definition of terms, what we're talking about when we talk about abdominal wall fellowships, a very whirlwind tour about what information you can find on the Fellowship Council website, the Schlosser spreadsheet, which I probably should trademark, and then a to-do list for applications. After this webinar, we'll make available to you the spreadsheet and the to-do list, so you guys don't need to take a bunch of screenshots or type really fast to try to get that. You will get a document that will have that to kind of base your start for a search off of. So I do not represent the Fellowship Council. I don't represent any specific fellowship, and I have no institutional or academic authority. I literally don't have a job right now, technically. So I don't speak for everybody for sure. I do definitely represent an abdominal wall enthusiast who worked for this really deliberately. Like I chased this training and these connections very carefully, and with the goal of landing an awesome fellowship, and I really think I did. So what do we mean when we talk about a hernia or abdominal wall fellowship? There's really two categories. The first category, we talk about a 1-year post-residency specialization training, and we're talking about independent or fellowship council. So an independent one, there's one at Cleveland Clinic, there's one at Columbia. Basically, an institution or hernia team will create a space for someone to come and work with them for a year. You find out about this through word of mouth, through social media. The International Hernia Collaboration on Facebook often has posts about these, up on Twitter. You get really intense hernia training with some of the experts, but you really can have one mentor and you're not under the fellowship umbrella. So, for better or for worse, this is not an ACGME regulated thing. It's a contract, an individual contract with that employer. Under the Fellowship Council, they have structured fellowships as a core curriculum plus additional specializations. They're currently piloting an abdominal wall core curriculum from 2023 to 2024. The participation and the criteria are not currently public knowledge. So that's not something that I can say these 8 places are piloting, you should try them. That's not currently public knowledge. And so when you look up for what under the Fellowship Council curricula, there's the core curriculum, and then they subcategorize bariatric, comprehensive flexible endoscopy, HPB, and MIS. And so how do you find out about them? I'm using my fellowship as kind of the example for these. When you go to the directory on the Fellowship Council website, you have 173 of all of these, and you have filters. You have filters that will let you search by geographic location and by specialty. So you can select, I selected for South Carolina, and I selected for Advanced GI MIS, and I found my fellowship. And usually your ABWAL fellowships are going to fall under Advanced GI MIS. That's usually kind of how they categorize themselves. And then you're going to find so much information on this website. I cannot stress enough how much useful stuff I was able to find on this as I was just starting to think about where I wanted to apply. So general program information, you're going to have your locations, your attendings, your affiliates, if you have residents, if you have co-fellows, if you are considered an attending versus a trainee, do you have full admitting privileges or not? Do you take independent call? Eligibility, so for international applicants, unfortunately, there's not a way to search for specific types of eligibility, but you're going to find whether or not they might consider you under the eligibility portion. Fellowship opportunities are going to have your salary, benefits, academic funds, and research expectations, and then you have program directors and contributing faculty. Who else are you going to be working with? How big is that team? Where the meat is, it's going to be under caseload. And so every fellow, just like you did in residency, has to report how many cases that they did. And so this is 2 fellows, 844 cases with 1,000 procedures during this fellowship year. This fellowship that I attended was half bariatrics, like very much half bariatrics, half MIS, mostly ABWAL. And so you can see that reflected. We have a large number of bariatric cases. We also have between us 150 incisional hernias, so 75 each during that 6 months that we were on that service. And then a big spread of other incisional of other hernia procedures that we perform. So there's and so you're going to look here for volume, for variety, for complexity. It doesn't flag whether something is a robot in this particular one. And then you can also look back in time and see what has changed. Do they suddenly drop off their foregut? Do they suddenly gain a bunch of colon cases? What has changed in their fellowship? And that's something you can ask about once you start interviewing. So they just posted the timeline. There's a timeline on the website. I literally just copied it here. Application process opens December 1st. You should apply on day 0. I'm going to say this again. You should apply on day 0. And this is because there are some fellowships that will cap how many applications they're going to review because they get a ton. And they're not going to review further than that because they're going to have great applicants in that first 50, 100, whatever it is. So apply on the first day. And then the rest of the timeline is going to have when the application closes, letters of recommendation, all of that sort of stuff. You're going to match in July, and then fellowships begin your next year. So first on your to-do list is to make an account on the Fellowship Council. You're going to research the fellowships, who on your team trained there. Send your advisors your list. Include specific questions like, do you know this person? What do you think of their research? Look at the websites, what is available to you there, and look at the fellowship website. What's the case split? What has changed? What sort of research there is? And then start thinking about what you want. Everybody's a little bit different on this. Some people have some geographic ties that are very important to them. Some people never want to take another day of call in their life. Good luck, but that's maybe important to them. And so I did what I always do. This is the patented Foster spreadsheet. I made a spreadsheet. I have the information about my first ranked place. It was Prisma, and the type of stuff that I captured. How many fellows do you have? What is the case spread? I noted there was lots of bariatrics. There was a good amount of clinical research. There were 2 fellows. There were residents. I actually didn't think we had attending privileges. It turns out we did. So that's something I corrected. And then I had a subjective scale from 0 to 10 on what I thought of all these different things that were important to me. The call schedule, the location, the technical autonomy, what the vibe was. Did I like them? All these things. And then some extra thoughts about what else about the faculty. I made a line for each one, and I made it as I first started looking at the website, and then I adjusted it after I interviewed. So other things to do, follow these people on social media, see what they post about if they care. Prep your CV and line up your letters of recommendation. I know this seems really obvious, but like tell your mentors in advance and give them materials to work with. Send them your CV, whatever essay you're putting on the fellowship website and your list of programs, and then give them a blurb on what your goals are so they can sell you because they may not remember you because they're writing a lot of letters of recommendation. And then finally, talk to people, your academic advisors, and who do you know who has applied to fellowship? Because they're going to have a lot of insight about kind of the dirt and what's gone around in the previous years and the impression that they got from different places where they interviewed. Finally, you make your list and you apply. Again, apply on the first day, just do it. Much like residency, virtual interviews have a very bloated application season. They're getting a lot more applicants for the same number of positions because people don't have to travel to interview. Use the interviews to fill out the unanswered questions from your research, your robot time, your case split, your what kind of research do they do? Do you want to do research? And ask the faculty about their interests. Show that you researched them and the program. I'm saying this because the difference it makes on the other side, if someone cares, it matters. And then update your spreadsheet or your notes, however you choose to organize your information, and discuss it with your advisors, and finally do your rank list. And that's going to be very personal. I'm going to pause there and we're going to do questions at the very end. Again, you'll get access to the structure of the spreadsheet and you'll adjust that for yourself, as well as the to-do list that you can adjust for yourself. Thanks so much.
Thank you. That was wonderful, as always. And congratulations on wrapping up fellowship and getting started with your first official gig. So next up is, again, Dr. Abhishek Parmar, who will be talking about what fellowships are looking for in applicants. Thank you.
All right, thanks, Bahag. So I'm Abhishek Parmar, like you mentioned, I'm the Associate Program Director of our fellowship. Disclosure in advance, if I'm a little bit loopy, it's because I have COVID. So apologize in advance if my talk gets to be a little bit silly at times. So I have financial disclosures and then a practical one. So the practical one is, obviously, I'm going to give you all a little bit of insight at our fellowship at UAB, which is a high volume. Abdominal fellowship is also kind of quite broad. So obviously this is just kind of our perspective and how we do things at UAB, and it's certainly not going to be representative for all fellowship programs, but is at least a window in how we do things. So to that end, these are the objectives, just so y'all have a little insight into the process. And the aim is really to empower y'all to improve your standing for interviews. I'll start with a little bit of data and then just go over our process and the details of the fellowship interview process from the perspective of a PD. So some statistics, there's been a steady and progressive increase in applicants to minimally invasive surgery fellowship over time. And I suspect that this red lines continue to go up as the applicants increase. Concomitantly, there's been a steady decline in the match rate. You can see here, I very artfully marked off minimally invasive surgery. You can see that minimally invasive surgery fellowships are now more competitive or nearly as competitive as pediatric surgery. So you can see the rank or the match rates dropping every year. So it's becoming more and more competitive and more challenging to obtain these fellowships. So like how the other discussants had already mentioned, and Dr. Schlosser very nicely went over, programs vary quite considerably. And I think it's critical to look at the case logs and case volumes. There's a wide variety in the distribution of cases. At UAB, we have a reasonable amount of abdominal and bariatrics, which is probably what our two largest components are. But then there's also other programs that have kind of various things. I did lots of minimally invasive esophagectomies at OHSU and adrenalectomies for some reason. So fellowships really vary in kind of the complement of cases that you'll see. So really investigate that on your own. Some fellowship programs have a clear agenda and a mission. We want to train an academic surgeon. You need to demonstrate this sort of background and pedigree and strategy for success in academic surgery. Take that into consideration as you pick your program. We don't really do that at UAB. We just find someone that we like. And then I like Dr. Schlosser mentioned, think about if you wanted to take attending level call. I didn't. I was one of those people that was very lazy, and I wanted to take it easy my fellowship year, just operate. But our fellows at UAB take attending call, and they actually really love it. It's kind of a transition to practice model, and they get to kind of test their skills as time goes on. So what is holistic review? The definitions can vary and can be broad, but really ultimately it comes down to considering the whole applicant, right? Then, for residencies, I'm sure y'all have been involved in interviewing medical students. You look at step 2 scores and maybe call it a day. But for holistic review, you really take into account the applicant's experience and everything that goes into what makes them who they are to find an applicant that's right for you. And that's really what I think we do at UAB. So every single application gets reviewed at our institution. And like Dr. Schlosser said, it is an advantage to apply early. We actually review every application and continue to review them well into February, even though our interview dates come to March. We review every single application. And this is kind of what we look into. And just to take away any potential weighting of anything, I just put them in alphabetical order, and I'll go over those in a second. So last year we had about 125 applications for our one spot. Our program director kind of reviewed them and puts them into tiered ranking quartiles, or I guess tertiles. And then I review them and suggest any changes, and then we ultimately set up with our list of invitees for interview dates. And it ends up being about 30 people we interview out of 130 or so. And then each interview day, we rank each applicant, and then we have a master rank meeting right away. So the rank meeting happens right after each application, right after each interview date, and then another one at the very end. So for outside scores, we look at outside scores. I was surprised when I interviewed that the number of times my outside scores were brought up as a positive thing. We don't really look at it so much in that sense, but we usually actually for negative predictive value. We see folks who have persistently low outside scores. We worry that they might have a higher risk of failure on the boards, and the possibility that they'll be less likely to comfortably handle attending level responsibilities. Again, as y'all know, the outside is certainly not, a linear correlate to your clinical ability, but it is something objective that we can use to weigh applicants. And this has been borne out in the data. Years ago, this might be a little bit too old, but the residents taking the American Board of Surgery qualifying examination with extremely low outside scores did have a higher failure rate. So we use this really to kind of flesh out maybe the borderline applicants. We look at case logs, really to gain an understanding of residence exposure. You really need to have a modicum of experience with some complex minimally invasive surgery. It's a red flag to us if you have, 0 Borea cases, not a whole lot of hernia cases, and 0 bariatric cases, because you really need a reasonable foundation for ability. Because at our institution, it's a very clinically busy program. You expect to function as an attending the day you show up. And so if you don't have that experience in managing challenging patients, we think you're going to struggle. Letters of recommendation, we actually read all these. Really want to get to know the applicant if we can. We want to understand the technical skill. Your letter writers will write some things that are red flags, because again, they're putting their name on a letter of support. Some things they might say is they've come a long way or they're growing technically. There's nothing wrong with coming a long way or growing technically, but again, we want trainees who are really in the upper tier of technical skill. And we also look for positives. Some letter writers will make shining statements, like, this is the greatest resident I've ever worked with. Here's my cell phone, call me. I will, fight to the grave to get them a spot in your institution. So it's really critical to understand your letter writers and make sure that they can write a strong letter. I say that again, you need to ask them for a strong letter. You're not just checking a box here. We had a series of applicants one year where the chairman wrote the exact same letter for every applicant. And it's very, very embarrassing, and it makes you look like not a very interesting applicant. To that end, though, you want to help your letter writer write a strong letter, right? You want to give them some background information to meet with them. You want to highlight your abilities. You want to tell them, look, this is what I want you to say in your letter. This is what I think I'm strong in. What do you think? And give them an out. Say, listen, if you can't write a strong letter of recommendation, just please don't write me one. Because at least for our institution, we really do look at it. It really can't hurt you. We look at a research portfolio, really to understand candidates' passions. Again, some programs want to train academic surgeons. They want to see 30 or 40 publications. The Fellowship Council has mandated a research experience in fellowship. They've actually been mandating it for years, but now they're actually enforcing it. So it is more valuable to have a fellow who has some experience in research and can conduct a project on their own, because that'll get you the required mandated research experience. And then we look at your background experience. We actually read that part of your personal statements to really understand what makes you different. So that's an opportunity to highlight what you value and help yourself stand out. Again, you're trying to make yourself interesting. To that end, the personal statement is probably my biggest pet peeve of the whole experience. If you go on Twitter or social media, you'll see any number, or X, whatever they call it now, any number of really valuable threads on the personal statement. And this is one of my favorites. And this is, for anyone who reviews personal statements, this is truth. So the yellow pie chart here, 98% of all fellowship or residency or medical student personal statements are fine, but they're bland, right? And you'll get a few that are probably poorly written, and that's definitely going to be a black mark. But then there's a very tiny sliver, that green 1% of people who tell a story that you say, I want to meet this person. And that's certainly happened to us. I think maybe every year that I've been here at UAB for 6 years and selected someone who might not have otherwise interviewed. So try to be that person. The people who are in the bland category, and I'm 100% victim of this myself, they ascribe to one of these recipes. You have an inspiring quote, tell a story, you go back to the quote. I've done that, I think, 7 times in my personal statement history. There's a hero story, my patient lived, the why I like your specialty, etc. So these are all very sort of formulaic. These are kind of what, again, the 98% will kind of go through and will kind of put on. But, if you really want to make your personal statement interesting, highlight some personal vulnerability. Tell a story that demonstrates, you overcoming something, and you demonstrated resiliency, or how it was transformative. If you've ever read David Sedaris, in 2 sentences, he can kind of enrapture the reader and really get you into whatever he's writing about. He could be writing about, the weather, but it's so fascinating, so interesting. Please don't explain why complex hernia is awesome, right? We know it. We love this stuff, right? All of us on the panel here, this is our passion in our career. So the point is to explain why you are awesome. I want to know what makes you different, and why we should be interviewing you. The interview date, I put it in quotes because it is a date, So the point is that you made it this far. It's not about your knowledge, your skill, etc. It's about, can we be locked in a room with you for 6 hours, right? Do you fit in well with our group? And so remember, everyone is watching you and judging you. There has been probably an applicant every few years that doesn't realize that our administrator is paying attention, and that they pay attention to the emails you sent and the way you respond to invites, and etc. So be careful, everyone is watching. Be yourself, right? If this is kind of like a speed date, and this is the first time we're meeting. But just like a speed date, you do have to show off your best self quickly. So if you're a little bit of an introvert, know that about yourself and really put yourself out there. And be honest with yourself. If this is not the type of program you want, Dr. Schloesser said perfectly, you got to go with the vibes. If you meet us, or you meet whatever program you like and you love them, then you love them, and that's your home. So be honest. That's it. But yeah, that's a little window, and I think we should have all of our contact information. If y'all have any questions, don't hesitate to reach out.
Wonderful. Thank you so much. What a great place. I know that I probably wouldn't have the ability to match at a place like UAB, but it's cool to see what people are accomplishing. So next up is gonna be a really special presentation talking about how you go from fellowship into practice, and we're gonna have Dr. Chait Vadlamudi present. Again, he's an assistant professor of surgery at MedStar Southern Maryland Hospital and did his fellowship at The Ohio State.
Thanks for that introduction, and happy to talk today. This is kind of an exciting topic to present on. Can you guys see my slides? Okay, great. Because I'm actually going through this transition myself. I'm in my 3rd year in practice after fellowship, and like you said, I am an assistant professor of surgery at Georgetown, but I only spend about 25% of my time there. The other 25% is kind of at our big county level 1 trauma center. The other 50% is at a community hospital with 300 beds that doesn't have any residents. And so I spent a lot of time kind of trying to think about what the best way to optimize my practices across multiple practice settings. And so I'm sure most of you guys have kind of seen this Dunning-Kruger effect. This was showed to me by our program director, when we started as interns to kind of just remind us that we don't know anything, that you kind of go through the cycle of learning a little bit, feeling overconfident, and to caution us from becoming overconfident. What you didn't tell me is that that cycle continues. It continues through residency, and then you go to fellowship, you feel the same way. And then you graduate and you think, you've passed your board, you're really good, and you start as a young attending, and you again feel like a complete idiot. And so there's really nothing that's going to fix that or prevent that from happening. But hopefully this presentation kind of softened the blow there and give you a few starters. Initially when I started this, I was going to talk about how finding your first job, but then I was reminded that it's really only a 10-minute talk, so I don't have time to go over all of this, but I will, have these slides available for you guys if you ever want it. And it kind of goes over everything. One thing I will say is that most of you have no experience with RVUs or billing or coding through residency, and most jobs, even academic, are becoming RVU based. And so at some point, they're going to tell you an RVU goal, and I behoove you to see if you can really get it by finding out what the case mix that you're going to get is. Is somebody taking all the foregut, all the bariatrics, and leaving you with the gallbladders and 3-centimeter umbilical hernias? Because you'll never meet your goal if that's the case. If this doesn't mean anything to you, that's okay. It meant nothing to me when I was a resident, but the ACS program does have billing and coding courses that are free for residents and fellows, and I'd encourage you to take it. Nobody has ever regretted taking that course. Your program director should help you kind of negotiate your salaries and see what's appropriate. There are MGMA standards, and that's where most of them come from. I don't really have time to get into all of this. But assume you got the job. You guys are all going to get a job, right? Everybody's going to get a job somewhere, and it's going to be much better paid than you got in residency. Please take some time off. You're not going to forget how to operate, and you're not going to lose your clinical competence. You 100% deserve some time off after everything you guys have been through. Also, you're never going to get 2, 3, 4 months off in a row again until you retire. And then when you finally do start, you're going to be frustrated because things are going to be really slow. You're going to be eager to get into the OR. You're going to want to be as busy as possible, and you're going to have 2 people in your clinic. Really try to enjoy and utilize that time to both build your practice and referral network and optimize your efficiency so you're not crushed when you do get busy. Building your referral network. So you need to identify your potential referrers. This is going to vary based on your practice setting. If you're in a tertiary academic center, there may be an existing referral pattern where everybody automatically refers to the surgery department and it gets split up. If you're out in private practice, it's going to be very different. It's usually some mix of those. So PCPs and GIs are usually kind of where we go to, but those have the hardest practice patterns to break into because they already know surgeons they've been referring to for 3, 4, 5 years that have had a good outcomes. And so I'd encourage you when you start with urologists, they stare at groins every single day. So they'll bring you in some good starter inguinal hernias, endocrine interference to bariatrics, cards and palm do a lot of paraesophageal, and then industry. And when we talk to the links reps, they can tell us in your zip code who are the highest PPI prescribers within all of GIs. And so you want to identify the referral patterns, where they're going, and then strategize on how you're going to disrupt this. Bringing breakfast and smiling and shaking somebody's hand usually isn't enough. You need to say why you would be a better option than what they already have and what your competitive advantage is. And you can get Da Vinci to kind of make these slides for you, and you can take them around and present them. So use all your resources, but don't forget that you're also referring physician. And so when you first start off, a great way to meet, other providers is to refer to them. I used to ask every single person that came in for a hernia if they've had a screening colonoscopy, not because I wanted to do it, because it was an excuse to refer them to GI. So then I would have an excuse to call that GI physician and see how he was doing and let him know who my name is. Most importantly, as you start off, never let a referring doctor find out about an operation or a complication from the patient. Always make sure you're the one to reach out to them, whether that's through a text, a phone call, message, email, whatever your system is. Make sure you develop a system. Every single doctor that you meet, get your cell phone number. It's very, very rare that anybody will abuse it. And I would encourage you to give your cell phone number out to any patient that develops a complication. And, really, especially early on, you need to be 150% involved with all your complications and very, very present. And guys, I'm not really keeping track of time, so I have a tendency to run over. So somebody cut me off if I come up to my 10-minute mark, okay? And this direct consumer marketing, this is becoming a bigger and bigger part, to me, unfortunately, of what we have to do to market ourselves. And so search engine optimization means somebody types in hernia doctor, does your name pop up first? It's the most expensive thing to do, but it has the highest probably reward to, dollars spent. And so you really should encourage your organization to get your website up and prominent. And then reviews are always a mixed bag, right? The only people that write reviews are people that are upset usually. And so you really have to direct patients to leave reviews. And we used to hand out these flyers, do all this stuff. It never works. People throw it away. Key your staff into keywords. When they say Dr. Schlosser is such an amazing surgeon, Dr. Shao saved my mom's life, your staff needs to key into those words and pull those patients aside as they leave, hand them an iPad and say, would you mind taking 2 minutes to fill out the survey right now? And that's the best way that you can drown out those negative reviews. You can't ever get rid of them. Social media, it's becoming a bigger part. You can either pay for somebody to do that or try to do it yourself. It is a little bit of a mixed bag, so please make sure you're HIPAA compliant, you're compliant with your organizational requirements, and that you protect your own personal privacy. You don't know who these patients and who these people online are. So this is just, an example. You get some really weird reviews, like, I don't usually refer people. Why would you even write that? I don't know. The best thing you can do is just try to, drown them out and use search and optimization to where you get good reviews that come up when people do search for this. And most likely they're not going to go past 4 or 5 reviews online. This is actually a residency mate who is very prominent on social media and has developed a really nice bariatrics practice. If this is something that's more your flavor, you can absolutely do this. And then obviously, when you build your first practice, you're getting referrals from people. It's really, there's a lot of trust that goes into sending a patient they may be known for 10, 15 years to have a surgery with you. And so I would say be really protective of your cases and yourself when you start. You don't need to be obligated to take on really complex patients or really complex cases. Limit your exposure. And when you do these higher, more complex patients, do it with a second attending or refer it out if you need to. And that's okay until you earn the trust, until you have like a larger end to go off of. If you've only done 2 colons and you have one of them leak, that GI is probably not going to refer to you again. And to that end, having a good mentor wherever you do work is actually very important. Now, in terms of optimizing your practice, and I'll kind of fly through this, you really want to secure as much block time as you can as early as you can. It gets harder and harder to get. I would encourage you to get on the block committee. You get really granular data about where block time is available, and you can rearrange your schedule. You also start to understand the rules and how to game the system. Like, you can release your block time and then book into it 2 hours later and get over 100% utilization, things like that. It becomes more important. It's very specific to each hospital. I would also encourage you to find an ambulatory surgery center. If it has a robot, great. If not, it's totally fine. But this is where you're going to do your smaller cases that go very quickly and don't earn you a lot of RVUs. That's your inguinal hernias, your lipomas, your hemorrhoids, your gallbladders. This is what makes it financially feasible. And this is also what protects your block time. If you're doing a 30-minute hemorrhoid and it's a 30-minute turnover, the highest block time you'll ever have is 50% utilization, and they'll take that away from you. Right now in fellowship, you can start copying templates from the attendings that you work with and trust and likes, and that means op notes, clinic notes, consult notes. Put that somewhere where you can have it, so when you start, you can start integrating that into your current EMR as an attending. Same thing for preference cards, and same thing for any equipment that you need. And understand that if there is any equipment that you need, you should ask for it early, because capital budget's only made about once a year. And so if you miss that window, you might have to go a whole another year. And it's something that you don't really think about. One of the hospitals I worked at didn't have Nathanson retractors, and so that was a whole battle to get them shipped from another hospital on the day of my surgery. Last thing I'm going to talk about is optimizing your office. This is so important, and I think it kind of gets glossed over in residency and to some degree in fellowship as well. You really can't grow, who you are as a surgeon, your operative value, without growing your clinic. But the more time you spend in clinic, is less time in the OR. So try to find ways to use NPs to your advantage, basically to see pre-op and post-op patients, that you're only seeing patients that are going to the OR. I think I'm close to 10 minutes, so I'm just going to end right there for you guys. Does that seem fair? Okay.
Fine. I have to admit, you pointed out a lot of things that I wish I knew when I was transitioning into practice, and I've just realized you work in a very competitive market. That's impressive. That was very cool. Are you sure you don't want to like wrap it up? Like, I think you should keep going, man.
You sure? Okay. Honestly, this is going to be my last slide. I think after this is just managing complications. It is actually really the hardest part of being an attending. You've obviously had complications as a fellow and a resident, but they definitely hit different when you're an attending. Even if you in theory did nothing wrong and it was kind of an inevitable complication, you made some decisions that led to that patient having a poor outcome, and you're going to have a lot of sleepless nights. So it's really important that you find a support system. It's hard to do that with your family, especially if they're not medical. So keep in touch with your peers that you meet on the residency trail, on the fellowship trail. And this is where your attendings become really important. You want to talk to other people that are in the same phase of career growth as you, and you want to talk to people that are more experienced. They can tell you that they've done much worse things. The chances are your complication is not unique, and you're obviously going through some level of imposter syndrome when you start. But I would encourage you to talk about your complications as much as you can. It really is the best form of therapy, aside from just getting back into the OR.
Wonderful. Any other thoughts before we move to the discussion? All right. All righty. Well, that was wonderful. Thank you so much. We're gonna jump right into it, right into the discussion, and start talking about some of the things that came up during these presentations. And so I wanted to ask Dr. Shao, you talked a lot about abdominal wall fellowships and why we should do it. But if you had to pinpoint maybe one or two of the most fulfilling elements of your abdominal wall fellowship training, what would you cite as the most fulfilling aspect of your fellowship?
Oh, it's so hard to pick. So I think probably two things. Number one was the cases. I felt like I learned something every time I was in the operating room, whether I was, operating with one of the residents and teaching them how to do a case, or if I was operating with my co-fellow, or if I was operating with my attendings. So I feel like I just grew a lot that year. It was kind of like finishing school, right? So after residency, you're sort of learning how to finesse your skills and how to be even better and how to be even more efficient. And I think the second part is definitely the community. I mean, I definitely loved where I went for fellowship. I have very like fulfilling relationships, with my fellowship attendings, but also my co-fellow and definitely just the community that I found at AHS. I think those are probably the two things that really stand out for me.
Wonderful. Dr. Schlosser, I wanted to ask you, sort of building upon this question. It sounds like you were very strategic in your sort of progression through your early career, defining hernia and ab wall as where you were going to land. What was the reception by your mentors at your early training years? And as you progressed and wanted to become an abdominal wall surgeon, what was the reception? And then when you did your fellowship, what do you think was the most fulfilling part?
I mean, I really think the reception for hernias was similar to it is in many places where it's like, it is definitely an underrated specialty. We're becoming more known as something that needs some extra expertise. But I think much of the early reception that I had was sort of like, why would you need extra time learning that? They're so easy. And so when I stepped out for research, that was within a structure that would accommodate me stepping out for research. And it was very strategic on my part to find a place where I would get published and I would make connections within that world, because I recognized that I was not going to have those connections at my first residency. That was not a place that had a lot of connections, both in academic medicine and in the hernia world. And then for me, what's been really rewarding is sort of when being able to problem solve and being able to add to a case. I think that's something that grew through residency, and then as a fellow, being truly a near equal partner with the people that I was working with, and being able to actually contribute sort of problem solving and where are we going to attach this, and do you think we can get a little bit more here. I think that growth, it was very hard to see day to day, but by the end was very, very apparent that I could sort of, do enough on my own or figure out enough on my own that they were glad that I was there. Not that they weren't in the beginning, but there's definitely a shift that happened.
Gotcha. Wonderful, thank you. Just to address something that's going on in the chat, a question about non-traditional applicants and whether or not ABSITE scores should be included. Most places are going to require you to submit ABSITE scores. And just to clarify my statement that was made in the chat, non-traditional applicants, I think, really now stand out even more than even in the past. I think having someone that's already trained and has experience is always a good thing. And now with holistic review becoming more commonplace, I'm sure non-traditional applicants will have even more opportunities to stand out for their unique qualities when applying to fellowship. All right, continuing on with the discussion. Dr. Parmar, you guide a lot of people into fellowship, and you are very involved in the selection process at your institution. Many of the people sitting in the audience today may not necessarily be at institutions with high volume, complex, contemporary abdominal wall surgery taking place. What are your thoughts on how an applicant can develop experiences in this domain to stand a chance at a place like UAB and other institutions that are looking for individuals with experience?
Yeah, thanks, Bob. Great question. So actually, I'm glad you asked me because I actually didn't do a high volume ABWAL fellowship. So my fellowship was really a hodgepodge of a lot of things, ABWAL being one small part. So I actually built my expertise and ability when I was a faculty member the first few years of my attending position. So I mean, there are a lot of resources. I think a very low hanging fruit, a great place to start is international hernia collaboration, because if you need to see or understand how to do something, not only can you just search, crazy flank hernia, you can find the person who repaired the crazy flank hernia, and you can ask them questions and you can talk to them to collaborate. The nice thing about the hernia community, like Dr. Shao has mentioned, is like everyone's nice. I mean, everyone wants to help everyone else. It's a great community. It's bizarre the level of mentorship that flows down from these leaders in hernia surgery all the way down to us. And you'll find people like, for me, Conrad Balliser and all these folks who are really willing to take on folks and mentor them, whether it's in person or through I almost said telepathically, through a phone, through telemedicine, or sorry, the COVID's really kicking in now, but there's a lot of avenues. So I think I would look out for industry sponsored events. There's a lot of sort of training labs you can do. Societies sponsor a lot of labs, SAGES and AHS every year. Every year, you could probably go to 4 or 5 different training labs. If you look at industry and AHS, SAGES, all those things combined. So, and all those places are opportunities to network. And the learning doesn't really end at those opportunities. They keep going for years and years. So I think if you use those avenues, you'll find the mentorship you'll need.
Wonderful. Thank you. All right. I'm hoping to get Dr. Vadlamudi to address maybe this question. You're pretty early on in your career, first few years out now. Where do you see the abdominal wall specialization going in the next 5 years?
That's a great question. I'm seeing more and more interest in this amongst general surgeons, and unfortunately, I think we're seeing a lot of the complications of people that are not properly trained. So I think, it is going to become something eventually that is, similar to board certified, or at least something you can get a certificate for. And I think, Center of Excellence are going to be something that insurance companies demand, for their patients, so that they minimize complications and kind of maintain the costs and risk. And so that's kind of what I see happening over the next 5 to 10 years. Just kind of being more highly specialized in high volume centers.
Great. Dr. Shao, you also talked about this a bit in your presentation, the concept of specialization. Do you have any insights to share with the audience about this and your vision of what an abdominal wall center may look like in the future?
Yeah, that's a great question. So I think some of this is already happening, right? Like you have a lot of referral centers, I think, across the country now, where people go for really complex redo repairs. I definitely think, Carolinas is one of them, Cleveland Clinic is another, Columbia is another. So I think you're seeing all of these like centers just pop up all over the country where people are sending patients that they don't necessarily want to operate on. I don't think the specialization is the sense that we're taking hernia surgery away from general surgeons. I don't think that's, the reality at all. I think at the end of the day, what we're realizing is, everyone can stand to benefit from better training in evidence-based medicine and hernia surgery. Ultimately, at the end of the day, when you go to a place that's more specialized, I think you're going to see, I think probably a difference in terms of, I think the pipeline of how you're going to get patients to surgery, the things that you're going to consider, the different types of things you're going to be able to offer, and maybe case complexity. And so I think with that, though, you're going to start to see a push also in specialization of fellowships. And I think at one point it's probably going to be its own fellowship outside of the MIS designation. So I think we'll see where it goes. I think it's a really exciting time to be an ab wall surgeon.
Wonderful. All right. Probably have time for two more, and then we'll leave it at that. Let's go ahead and start with ask Dr. Parmar. You've been in practice now for a few years. What do you find as the most gratifying element of being an abdominal wall surgeon? Some people in the audience wondering if this is for them. What do you find?
Yeah, no, great question. I think, for me, being an ab wall surgeon really, and I felt this when I was a R4 as a trainee, I think it really magnifies what we all love about surgery, right? You fix problems. And you can talk about, recurrence rates, et cetera.
I think there's someone that's not muted, but I don't have the ability to mute it.
There we go. Thank you. So I think and what I tell the residents is, you win, right? So when you do a robotic abdominal wall reconstruction, the patient goes home, the next day, the day after, and they feel great. Your follow-up and the recurrence rates are low. It's a satisfying experience. There's a lot of specialties in the surgical world where you labor. I have a lot of hepatobiliary friends who are phenomenal technical surgeons, but those patients don't do very well, and they progress poorly, and they have recurrent cancer and et cetera. So for ab wall surgery, you really do get to win, and you see the benefits of your technical expertise. If you do a good job and you prepare the patient well, they do well. And I think that seeing the fruits of your labor is really satisfying for me.
Yeah. All right. And for those in the audience that are about to transition to practice, Jenny Shao, what would you say? What piece of advice would you give yourself early in your career when you first started out in terms of what to expect with transition to practice?
Yeah, I think definitely don't hesitate to ask for help. So, if you're doing a really complex case, maybe this is the first one you're doing outside of fellowship, have one of your senior partners there. I did this all the time my first year as an attending. I would just give them a heads up, not that they had to be there, but I would just say, hey, like, are you operating this day? Like, I have this really complex patient. Or sometimes, if I saw like a really complex consult that wasn't necessarily in my specialty, like something surgical oncology or hepatobiliary based, even though I feel like I knew what to do, I would run it by one of my senior partners who is, more knowledgeable in HBV surgical oncology, just to make sure I was making the right decision. So I think, it never hurts to communicate early. And I think when you have the right partners, they should be willing to really back you up and help you out.
Great. Dr. Vadlamudi, you talked about how challenging complications can be early in your career and some of the strategies you've used to mitigate them and also prepare for them. How have you coped with that, and who have you used in your life to get through those difficult scenarios?
Yeah, that's a great question. It's something I think that we'll continue to deal with our entire careers, and it never gets that much easier. When you start off, I would say try to mitigate those by, coming up with criteria for yourself. I'm not going to do BMI over this. I'm not going to do a recurrence of this kind, and start with that. And then once you start doing those, like Jenny said, get your partners involved. When you do have a complication, it really does help, I think, to talk to anybody about it. Anybody that's willing to listen. And I think getting back into the operating room is the next best thing you can do. It'll restore confidence in yourself. And I don't know. I mean, is that what you were asking?
Yeah. Great. All right. Well, I think we're out of time, unfortunately. I know these conversations can continue on much, much longer. We want to thank again our corporate alliance sponsors who help with these events. And we want to thank the audience and our participants today for showing up and being very honest, very transparent, and sharing your experiences with us. So thank you very much.
Bye, everyone. Good luck with everything, and let us know if you have questions.